So there's a couple people in the pain field who are fortunate enough to have a first name that you don't have to even use their last name. We have like Afton and Yenisel and Susmita. And Susmita Kashikar-Zuck has done really groundbreaking work in pediatric pain. A lot of her early work in her career was in juvenile fibromyalgia and following the cohort of kids with fibromyalgia to be adults with fibromyalgia, but she's really broadened her work into more broadly working in pediatric pain. So she's going to be talking to us today about COPCs in children. Susmita?
Thanks so much, Dan, and thank you, all of you, for those of you who are here. I was like, okay, everybody's going to be bailing on me and networking, and
I'll get them in.
but people are trickling. They'll trickle in. The important people are here, so we will get started. And what a great set of presentations today and yesterday, of course. And I'm learning so much. And I will tell you that. This is a really important talk. I'm very glad you're here because you really need to understand that those of us who are in the pediatric world are really trying to push this field forward and learning from those of you who are in the adult pain research space because there are so many more advances going on. But I think a lot of it has to really be translated into the pediatric world as yet. So I'm very interested to hear your thoughts and reactions, but I'll tell you about some of the work that we've been doing over the last 25 years that I've been at Cincinnati Children's Hospital. So greetings from Cincinnati, from the lovely city on the Ohio River. That is the Children's Hospital, and the top right picture is the center building, is the building where I do my work. That's our clinical research building. And as far as disclosures go, I have no conflicts of interest to report related to this presentation. But I do receive grants from the NIH as well as the Childhood Arthritis and Rheumatology Research Alliance, which is a group of the pediatric rheumatologists in North America. And I'm one of the I think 4 psychologists that's part of this group, but they are a wonderful group of collaborators and also from our research foundation. So my objective today is to just sort of outline why pain in childhood matters. Why does it matter that we start looking at pain early in life? And then, as Dan said, I've done a good bit of my work in juvenile fibromyalgia, which is sort of one of those exemplar conditions of chronic overlapping pain and sort of multisensory and dysautonomia and multiple symptoms. The challenges that we have in proper diagnosis in pediatrics and some of the barriers around that. I'll tell you a little bit about longitudinal studies, and in particular in fibromyalgia, that we have done. And a lot of my work has been focused on clinical trials and doing primarily non-pharmacologic interventions for teenagers with chronic pain, and tell you a little bit about future directions. There are a lot of future directions. I could talk on that a long time, but I'll just tell you some of the key ones that I feel are important. So as Rob talked about, the biopsychosocial model, you've heard a lot about that in several of the talks today. And so really, we have the biologic factors, psychological, social factors that impact the pain experience. And this was sort of the only visual I could think of to describe just how much looking at things from a developmental perspective is important when you are doing research on pain in children. So for biologic factors, the brain is still developing. The musculoskeletal system is still developing. Your inflammation, related to the types of diseases they might be exposed to, and immune mechanisms. The immune system is still developing. So all of these things look a little bit different not just quantitatively, but also qualitatively in children. Psychological factors, anxiety, catastrophic thinking. I mean, when you're a teenager, catastrophic thinking is sort of fairly normative, right? So, if you have had a bad hair day, it is a really bad day. And so, things like that are developmentally, you got to know what you're dealing with here. And also family, school, the school environment, the peers, the types of social relationships that happen in school. And so, these things really should really influence and have really influenced my work in pediatric pain. And it's interesting that over the years, we now have a really nice group in Cincinnati of people who are doing basic science, translational, and other research. And Bob Coghill, who's one of our neuroimaging faculty and has done a lot of work in adults with chronic pain, he was like, I love doing neuroimaging work with children. You just have, like, their brains are just so like nice and clean and plump, and they just, it's wonderful. So it's just a different experience. So in 2021, there was a special commission, a commission paper, a commission issue by the Lancet Child and Adolescent Health. And so Chris Eccleston and a bunch of, internationally known pediatric pain researchers put together this paper. And really it was a call for action. One is make pain in childhood matter. It's important, and we need to communicate the importance of this. Make it better understood, because at this point people talk about it, but really our understanding is still, not optimal. Make pain in children visible. We don't talk about pediatric pain in a lot of our pediatric clinics and in a lot of our subspecialty clinics. They talk about symptoms, they talk about inflammation and things like that. But a lot of times, pain is just not something that's addressed very well. And of course, make pain in children better. What are the best treatments that we need? And as part of this issue, I was able to write a commentary, which is, let's also focus on transition of care for adolescents with chronic pain, because that is a time period that is of crucial developmental importance, but transitioning from pediatric care to adult care is a whole field that we really need to understand more about. So some of you already know this, but chronic pain, that is pain greater than 3 months, is common in children. Approximately, depending on the paper, 1 in 4 or 1 in 5 children experience chronic pain. And the most common conditions are headache and migraine, limb pain, abdominal pain, and musculoskeletal pain. And then a subset of patients will have chronic widespread musculoskeletal pain. Now you have the ABCD study, you have some other studies, longitudinal studies, where you can look at this data a little bit more. But really, the best estimates that we have is between 3 and 5% of school-age children have chronic widespread musculoskeletal pain. Not all of these will be treatment seeking, but this was just based on sort of a school-based study. And after puberty, chronic pain is more prevalent among girls than in boys, as you might imagine. And in my early research years, I just had to almost prove to the people I was working with that, yes, this is a problem. It is affecting children in enormous ways, because the tendency was children are growing. A lot of this may be growing pains. You will grow out of this. And that this was seen sort of as more of a temporary thing that really didn't affect children's lives quite as much. So many of my early papers, and I came to Cincinnati Children's to sort of set up the pediatric pain clinic with my anesthesia and other colleagues, was just using our clinical databases to show that chronic pain was interfering with daily functioning, with school, sleep disruption, peer relationships, their social interactions, their feelings of loneliness in the classroom, the anxiety, depression symptoms that came along with really feeling like you weren't in a situation where you could control what was going on with your body, the impact on the family and family relationships, whether that was with parents, siblings, and so on. And also the healthcare utilization, because often patients would go from specialist to specialist, particularly in those who had chronic overlapping conditions where they might go to GI, they might go to neurology, they might go to other subspecialists. And in one of my studies with fibromyalgia in particular, we found that it takes an average of 2 years to get a diagnosis of chronic widespread pain or fibromyalgia or amplified pain, or whatever. There's a lot of terminology going around out there. So this was from a paper we published in Nature Reviews Rheumatology in 2014, I believe. And just sort of describing juvenile fibromyalgia and sort of the symptoms, and just kind of to reiterate what you all have talked about earlier today, is sort of these overlapping symptoms with the fatigue, the sleep difficulties, cognitive difficulties, and the other somatic symptoms, the dysautonomia that goes along with it, and also the tremendous impact it has on the lives of these young people. So the earliest recognition, I think this was Muhammad Yunus and Massey were the first ones in 1985 to come up with even have some sort of criteria for the classification of fibromyalgia in young people. And it was probably around that time, maybe even in the early 90s perhaps, that pediatric rheumatology and pediatric pain clinics began to even document that there were patients coming in with these conditions where they had overlapping symptoms of pain, fatigue, sleep problems, headaches, digestive distress, dysautonomia, and so on. The other thing that wasn't mentioned in many of the adult talks, we see a lot of joint laxity syndromes in children. So a lot of joint hypermobility. And I remember once going to, I think it was APS or USASP, and I was talking to one of my adult research colleagues, and I mentioned hypermobility, and they were just like, oh, you mean ADHD? And I was like, no, not that kind of hypermobility. I mean, like joint hypermobility, like these really bendy kids. So we do see that, and that is also connected with a lot of joint dysautonomia. And so there's actually a genetic condition called Ehlers-Danlos syndrome, but there are these joint hypermobility conditions that are considered sort of benign joint hypermobility, but those can also be associated with pain. And so a lot of times, they would be run through different medical tests, which were, of course, not necessarily significant in showing any kind of disease or inflammation. And so the pediatricians or the pediatric specialists would just call it, some kind of chronic pain syndrome. And part of the difficulties in diagnosing JFM is something that I'm sure happened with fibromyalgia at some time, but there are so many different terminologies, even up to now, in terms of calling it generalized pain, amplified pain, juvenile fibromyalgia, diffuse amplified pain, myofascial pain, chronic pain syndrome, some version of Ehlers-Danlos syndrome. And so are all of these same? Are they different? And does it matter in terms of clinical care and how we provide care? Does it matter that we have an accurate type of terminology? And we've heard a lot about terminology today, and nociplastic pain, chronic overlapping pain, amplified pain, the central sensitization. Where are these overlaps? And again, of course, with the multiple comorbid symptoms that go on, it does make it more complicated. And so I actually asked both my colleagues, pediatrician colleagues, and I've also spoken a lot with patients. And I was like, why does it matter? Because when I started this, so my training was in adult chronic pain. And so, I treated patients with adult fibromyalgia and everything, and I said fibromyalgia, and people seemed to know what that was, and that was fine. So when I came to work at a children's hospital and I talked about fibromyalgia, I got this look like, oh my God, she said the word. And I was like, really? This is kind of what it looks like. They have widespread pain, they have sleep difficulties, they have cognitive difficulties. Looks like fibromyalgia, acts like fibromyalgia. Why don't we just call it fibromyalgia? And So over the years, I've come to realize, so this has not been resolved at all in pediatrics, I will tell you that. And in fact, 2 years ago, was it 2 years ago? Okay, I gave the plenary keynote address at a conference. And my title was something about juvenile fibromyalgia. And I was asked by the organizers, can you please change your title? Because you will upset a lot of people in the audience. And so this was an international conference. And so I was like, fine, I'll call it chronic widespread pain, and we'll go from there. But people are still very exercised about this. And so I asked some of my colleagues, it's like, what would happen if you did say fibromyalgia? And so pediatricians tend to be very protective about the families and the patients that they treat. And they said, if we tell a child or a teenager that they have fibromyalgia, they're going to look it up online and they're going to read all the, these very scary stories about this is something that never goes away, and it's very disabling, and your life is over, kind of thing. And I was like, you know what? Teenagers are pretty smart, and they're probably online already, looking up their symptoms and things like that. And so in their heads, they know, they might have a parent, oftentimes it's the mom or a female relative that has fibromyalgia, is being treated for fibromyalgia in the family, and they're like, wait a minute, I've got the same symptoms, why are you calling this something else? And so it does get it does get confusing for families when they hear different specialists call the same condition different names. I mean, I personally don't have a stake in juvenile fibromyalgia necessarily, but I'm like, at least it is a term that people seem to understand. And we may get better at this over time, but let's at least try to keep it similar to the way we are doing research in adults, for instance. And knowing the research that's going on in Michigan and in Florida and all these places, I'm just like, okay, then we can at least do some more research. We can look at the mechanisms behind this, but if we cannot agree on what it even is, it's going to be hard to do. And I asked patients, it's like, how do you feel about receiving a diagnosis? Is this scary? Like if somebody told you, if your doctor said, you've got this thing and it looks like it meets criteria for something we call juvenile fibromyalgia. And most of them, specifically those that actually got a diagnosis, they were just like, no, it was a huge relief, because we kind of knew this is what, and everybody's dancing around it and not talking about it. But as soon as they told us, we were like, yes, okay, now we can move on and actually start getting care, because otherwise they were still hopping around looking for a diagnosis that fit their mental representation of what it is they were suffering from. So this is still an issue that's going on in the field, and so I just want you to be aware of that. And several of you have talked about adults who were symptomatic much earlier, whether it was with chronic migraine or whether it was with some other type of COPC, but they were probably in that phase of going around and having sort of the scattered care and not having the right terminology and probably not getting the right types of treatment. And this can have unintended consequences over time. So recently I had an informatics student that was working with me, and I was just curious. So I was like, there's all this buzz about ICD codes and how things are being diagnosed and so on. So can we I have close to 100 teens who I know meet all of the classification criteria traditionally for fibromyalgia. They have widespread pain and so on. And they were participating in my trial, so I had very carefully gone through and made sure I had all the right classification. I said, if I give you these, the medical record numbers, can you go into Epic and can you find all the ICD codes that these young patients have received through all the clinics they've seen in the hospital? And so we just did this sort of data dump from Epic, and we have this platform we use called RoomSmart that allows us to query Epic. And so we pulled all the ICD-10 codes. So ICD-11 is not, I think they've started, but this was like looking backwards. And as you can see, they had many multiple different diagnoses, all right? Many of them were in the musculoskeletal realm, all right? So fibromyalgia was generally there, but there was also the hypermobility syndrome came up a lot. And then pain in specific body areas, and then you have the neurologic symptoms. You have, there's another, so this, there is apparently something called the fee code categorizations for ICD diagnoses. So we kind of use that, but it's not perfect because there are some that are that come under the umbrella of symptoms, and a lot of our patients have symptoms that don't specifically fall into one of these codes. So I just put this up there because I just thought that was interesting. And then we're taking a deeper dive now into, this was just all the diagnoses that appeared in the medical charts. And then what I want to do now, as soon as I can get maybe another student or somebody to help me with this, because I'm not an informatics person, but I want to extract their journeys. Like if they came in through neurology, all right, and they got a migraine diagnosis, and then how long did it take to then, maybe go to GI, and then, or maybe eventually make it to rheumatology, where they were diagnosed with a widespread pain condition or something like that. So I want to look longitudinally what was happening in the medical charts, because I think that would be informative to see why it takes 2 years on average to actually get a diagnosis of a chronic overlapping pain condition. So for the moment, what are we doing about it? Clearly, we need proper classification criteria, and we did a small study in 2014. It's probably been almost 10 years ago. We did a small study where we used the ACR criteria at that time, see if we could apply it to children. And so at that time, we didn't use the Michigan body map, but we had used the widespread pain index, we used the symptom severity questionnaire, and really it worked really quite well in distinguishing those who had localized pain conditions versus those who had widespread chronic pain conditions. And so we were like, okay, we can use this. And then at one of the CARA meetings, which is the childhood rheumatology group, we actually shared these criteria and what we were finding with the pediatric rheumatologist communities. And they were like, hey, there are certain things we would need to add to make this more applicable to pediatrics, because there were some items in the symptom severity checklist over there that were like, well, these don't really apply to children, but there was some that too, and a couple of those had to do with the sort of dysautonomia, the dizziness, the sensitivity to lights and sounds, which our rheumatologists hear a lot about from the patients coming in. So we kind of modified that somewhat, and we've just completed a study with funding from CARA, which is great because this is coming from the rheumatology community. And Jen Weiss, who's at Hackensack, is the PI of that study. We did a multi-center study where we're trying to validate some of those criteria. We've just finished collecting the data, and we did collect it on the Michigan body map, as well as a whole host of the symptoms. And we're looking at children who have sort of a clinician-diagnosed JFM condition versus those with a localized pain condition who are coming from a pain clinic, versus those who have a rheumatic disease, so those who have juvenile arthritis, but do not have widespread chronic pain. So they have a rheumatic disease, but they do not. So we're comparing 3 groups and seeing sort of how well we can classify them. So we're working on this, and hopefully, it's been a long journey because we've had to work through we just need to get people interested in doing this. And now we've got sort of a core group that is working on this and developing criteria and that sort of thing. So we're getting close. And one of the things our rheumatologists had asked me very early on, because they were saying things like, everything from, you will grow out of this, it'll be fine, you'll be great, to, you better get used to this, you're gonna have this for the rest of your life. And patients wanted to know, the parents wanted to know, is my child gonna be able to go to college? Will they be able to live on their own? Will they be able to, have a family. And so they had questions like this, and the physicians were not very clear what exactly to tell them. And so there was everything from kids are inherently healthy and resilient and they will be fine and grow out of it. One of the other things that would happen is because of the psychological features that go along with not having a lot of sleep and just generally having mood-related issues and things going on in school, it became sometimes easier to say, oh yeah, well, it's just more sort of a school avoidance syndrome and it's purely psychological, and so once you get, go see the psychologist and you can get back to your activities. And at that time, there were no studies on the biologic mechanisms of chronic pain, and the lack of data led to confusion about how this was all handled in the clinical setting. So just very briefly, this was one of the studies we did early on, where we followed about a little over 100 patients with JFM and age-matched healthy controls, and we really characterized them at every time point at the age of, so they were about 15 years old on average when they were first diagnosed. And we administered measures of pain and psychosocial function. And we actually did home visits because we would talk to the family, and we would speak with the patients. We would do like a full battery of tests on the parents as well as the children, because we were also getting parental family history of pain, those sorts of things. And then so we followed them up at about age 19, and then at almost 22, and then when they were almost 24. And what we found was literally everyone in the fibromyalgia group had some level of symptoms when they became adults, okay? Now, this is not to say that they all had pain. They had pain that sometimes would sort of come and go, but they would, most often it were symptoms of fatigue, sleep difficulty, and other things. And then they were just like, but when I'm really stressed and when I have exams and other things, and then I notice that my pain also flares and other symptoms also seem to come up at the same time. So it seems like there's somewhat of a waxing and waning of symptoms. Now, over half of the patients, by the time they were 23 or 24, met adult criteria for fibromyalgia. So they were the ones that were then going to adult rheumatology clinics. And they were probably the most complex. But the ones that were basically, they had some symptoms, but were essentially leading fairly normal lives. They were, going to college, getting married, whatever. They may still have symptoms to some extent, and 80% of them had some amount of pain, but the pain was not always the most. So, a lot of our studies sometimes I see in the adult area may be focused on those who are treatment seeking. Well, what about those who are somewhat subclinical, may have been treated earlier in life, but then, they have some symptoms, but then they kind of adjust to it, get used to it, and are coping with it, and continue on. So there are some that are actually coping pretty well and doing fine, and then there are others that are more complex. And what we found was those with the more sort of more overlay of depressive symptoms, sleep difficulties, and things like that, those were the ones that continued to have more problems over time. And then what we did was we did qualitative interviews with those who were young adults. And looking back, I was like, what was it like for you as a teenager? And so it really started out with things like my doctor didn't really understand how to manage my pain condition because he didn't really understand it either. And then as a teen, I thought my life was over. I got to a point where I was just too exhausted to even have friends because they were just so tired. And then they're just like, you just want some validation. Like, you're not crazy. There's something going on, okay? And just emphasizing that it is multifaceted. You can't just tackle one side of it. Like, we want to be treated as human beings. And then, they may have gotten to the pain clinic or somewhere, and it was like that explanation, which was sort of that pain neuroscience education, the pain gate, that just helped things click for me. Like, oh, okay. This is something that can affect me in such a way. And then one person said, not until this year did I actually seek mental health care if I had acknowledged my diagnosis earlier. So there's this great this thing came up a lot, is really wrapping their head around the diagnosis. And some of them were just like, not only were the physicians dancing around the diagnosis, but so were the patients in a way. They're teenagers, they're like, no, I don't really have this, like, leave me alone. And some of them took a year or more to say, okay, you know what, I need to figure out a way to deal with this and really come to that level of acceptance that there is something that they're dealing with. And then they sort of get to that point where they start incorporating physical exercise and, you know, some of the psychological skills and things that we do. But it's that developmental phase that you're catching them at. And so we've been doing a lot of studies, you know, along with Marina Lopez-Sola, who's now in Barcelona, Bob Coghill, and that group. And, you know, just looking at pain sensitivity in teenagers, in healthy teens, as well as in adults. And this was one of the coolest studies. So Marina and I think it was her graduate student at the University of Cincinnati at the time, just took healthy teen girls and adult women, so no fibromyalgia, no chronic pain syndromes, and just looked at how their brains respond to pain in the scanner, you know, with the little thumb masher doohickey thing. And so what's interesting is that in adult women, healthy adult women, you know, you have the primary sensory cortex, it lights up, you know, your brain knows what it's doing. This is a sensory stimulus, they get it. In healthy teenage girls, not only do the primary sensory cortex and other places light up, but the emotional areas of the brain also react. And because the brain is still in this developing phase where it's trying to make sense of this stimulus, like, is this a horrible thing? Is this gonna hurt me? Is this ever gonna go away? You know, there's much more emotional input into this very simple pain stimulus, evoked pain stimulus, and this is just in a healthy brain without even chronic pain. So there are clearly developmental differences in how a pain stimulus is handled by the brain in a developing brain. And then, of course, we followed that up with studies in teens with fibromyalgia, and they certainly saw some of the differences very similar to what you might see in adult fibromyalgia, but then also detecting more of the sensitivity to lights and sounds, so a lot of unpleasantness associated with that. And so clearly we need a lot more work in, of course, you know, neuroimaging studies, but as well as immune function and genetics and so on, because, you know, in the younger patients, it's probably a little bit easier, again, being somewhat cleaner systems without the effects of a lifetime of all the different history of other comorbidities and so on. Probably need to start looking at this because it does cluster in families very clearly. And so this was the study I talked about where there is increased sensitivity to pain, particularly in the teenage years, and the nociceptive signal processing at the CNS level. And there's greater brain involvement of regions for emotional appraisal and emotional regulation, just in healthy brains. So these are just some of the papers that came out of those studies. So what about treatment? At the moment, the medications that are available, first of all, are mostly used off-label because there are not pediatric indications for most of these medicines. So there's a range of medicines that are used. With teens in particular, not a lot is known about the long-term efficacy of those medicines, and sometimes tolerability can also be a bit of a problem. Plus the black box warnings for use of antidepressants in teenagers sometimes can be a deterrent for some families to want to use some of those medications with the children. And then we've done some work on CBT. We did a trial where we compared 8-session CBT with an attention control condition, found that CBT was more effective, and the effects were long-lasting. This was primarily on looking at sort of pain interference, ability to do things, and so on. And then there were some studies in exercise, some small trials, and clinical programs So the multidisciplinary clinical programs, Dave Sherry had one at Children's Hospital in Philadelphia. Boston Children's Hospital has a program as well, and they had published findings showing that these intensive exercise plus CBT programs are very useful in both pain reduction and reduction in disability. So in 2020, the WHO actually published their guidelines for the management of chronic pain in children, and they emphasized that pain should be treated from a biopsychosocial perspective, which is great. And it should not be seen as primarily just a biomedical problem. And access to pain management is a fundamental human right, and so children should also be treated. And they recommended physical therapies, and they recommended psychological therapies like CBT and appropriate pharmacologic management. But if you look at all the certainty of the evidence, it's all low to moderate because there just weren't any great trials. There's more in the CBT area, but not a lot in physical therapies and pharmacologic management. So after the CBT trial, I got really interested in sort of movement-based therapies and started doing collaborations with our sports medicine colleagues because physical therapy was not very easily tolerated by the patients we were seeing clinically. So we would recommend physical therapy. They would do their sessions, whatever, but not really stick with it. So we really started to focus on developing more appropriate types of physical exercise interventions and combining those with psychological interventions, which led to our Fit Teens trial, which we have just completed. This was just a long, long journey getting this done. We had to, the thing is when you do pediatric trials, you need 7 or 8 centers just to get a couple hundred patients because these conditions are more rare in children, and so you have to do these very large multi-site investigations. And so we combined the exercise and the psychological coping skills training and called that the Fit Teens program. We used integrative neuromuscular training, which is really a sports medicine injury prevention approach, which we really started to apply, which was really a lot of fun for the kids because then they were kind of working out where the teen athletes work out. And so very quickly, we had the combined interventions compared to individual interventions with just CBT or with just exercise. They were group-based, converted that to telehealth right in the middle of COVID hit us, right in the middle of our trial. But this is kind of what it looks like when the teens are exercising together. We just completed the trial last year in which over 300 teens with fibromyalgia were enrolled, and they got either the Fit Teens program, CBT, or graded aerobic exercise only, which was a circuit-based program which we made very, very tolerable for the patients to engage in, and we got really good adherence. Surprise to us was that all treatments were, so there was a huge main effect. There was a really strong main effect for treatment. All 3 treatment groups improved. These were all active treatments. We didn't have a usual care comparator, but improvements were maintained over 1 year. And the first improvement we saw had to do with reduction in pain interference and, ability to get back to their usual activities, and then pain started reducing later, like 6 months after treatment. And there were minimal adverse effects other than a little bit of muscle soreness, and we're starting to make this more available soon. And so really my goals are first to educate more health professionals in primary care and in pediatric subspecialties about how to screen for some of these chronic overlapping pain conditions, and with fibromyalgia as we develop these criteria, and more studies looking at the underlying biology of these conditions so that we can develop more effective treatments. And really transition of care is something that is near and dear to my heart because transitioning is not easy from pediatric to adult practice. And there's a lot of systemic and logistical sorts of issues, not to mention the developmental sorts of things that families are dealing with. And the idea is to get more effective and accessible ways to engage with and train young people with chronic pain and self-management techniques. And again, ensuring insurance coverage for all these things would be crucial. And we have a huge group that I would, express my heartfelt thanks to. We did this across several sites. Riley Children's Health, Children's Mercy in Kansas, Sick Kids in Toronto, Boston Children's Hospital. And thank you all for your attention. This was our group of trainers in the Fit-Teens trial and some of our patients that were part of this and really were tremendous. So in wrapping up, I have a surprise person who would like to say a couple of words. So Erin, did you want to just come and say, I met Erin for the first time, and she's volunteered to say a couple of words.
Hi everyone, my name is Erin. I'm a K-12 PWLE mentor, and Fit-Teens saved my life. I'm still getting emotional.
I didn't know. I didn't even know that Erin was in the trial. I just met Erin yesterday, and she was like, I went through this program. It was called Fit-Teens, and I was like, really? And so we just kind of gave each other a hug.
Yeah, I participated in this study my sophomore year of high school, about 3 years into my pain journey, and it was a really hard time for me. I had put in all this work to get better, and I had about a year of being disabled free, and then my sophomore year of high school came, and I was worse off than I was when I had begun my pain journey. And so Dr. Logan, one of the site investigators, she was my psychologist, and she recommended that I participate in Fit-Teens, and it truly did change my life. It was only 2 months, and I was in the PT arm, so I didn't do CBT, but I immediately started feeling better, just having a routine set for me, and feeling like I had some control again when, at that point in my life, I felt like everything was out of my control. It made me really inspired to become more involved in chronic pain work and ultimately research. It's why I'm here now. And I was going to tell her before she had even told me that she was the PI that it was the reason that I am here, and it's why I am so passionate about chronic pain advocacy, and it's why I'm so passionate about meaningful healthcare research, because it does have tangible effects on the people that you are hoping to help, and it does change lives. And I'm just so grateful that the Fit-Teen study came into my life when it did, because I would not be standing here without it. I would not be working as hard as I am to manage my own health conditions. As difficult as it is, the transition from pediatric to adult care has been absolutely brutal, but I am so driven to give back to the people that are affected in the same way that I am and help everyone move forward, because there's so much more to life than pain, and it is very much possible to live with both pain and pursue your goals. I finished college, and that was not something I had expected. At the time of starting Fit-Teens, I thought I wasn't going to make it, and I'm preparing to go to medical school now, and I'm more impassioned than ever to be in this space and advocate for people like me who just don't know how to get involved and don't know how to get better and what resources are available for them. So I really do want to say I appreciate all the work that you do. It makes a difference, and I hope that you continue, making an effort to reach out to people like me, because we are just as desperate to find answers as you are, and we just want to help. So thank you.